Next slide. Okay, so what I'm going to talk about today is our Cure TB Transnational Continuity of Care Program, and I am with the Division of Global Migration and Quarantine, which is part of the National Center for Emerging Zoonotic and Infectious Diseases at CDC. Next. Here's the objectives that we need for the CE credit. So how to submit a referral and what services we have available, we will be reviewing. Next. I have no conflicts, no disclosures to provide. And next. Okay, so there was a lot of interest in the topic of migration and tuberculosis, but as I go to different meetings and read different things, most of that interest is with screening before people migrate into a country, and there seems to be less interest or focus on people who are already diagnosed, in the process of diagnosis, or actually on treatment, who then leave someone's country, and so out-migration is much less focused on. Next. And as we all know, that every year, the proportion of non-US born individuals who are reported with TB in the US is increasing. We're somewhere around 70%. Next. And that most states in the US over the last decade have 50% or greater of their incident cases among persons originally born outside the US. And that's important because people who are born outside the US have a higher rate of actually leaving the US at some moment during their treatment. So this will probably be an increasing at least percent of cases who may be traveling outside the US before treatment's completed. Next. So there's actually on the report of a verified case of TB, the form that CDC requires when you report someone, there's actually a field at the end of treatment that you can indicate if the person moved during their TB treatment. And if they did, you can say, did they move in the state? Did they move out of the state, and to which state in the US? And then, or did they move out of the US? And you can specify which country that is. And the last year for which that information is complete and available is 2015. And you can see actually there were 375, 4% of all the incident cases that year were people who actually moved out of the country before treatment was completed. And they went to more than 60 destination countries. So you can see the conundrum and what we need to do to get these people completed. So next. So Cure TB, we actually began this program quite some years ago for our own local purposes in San Diego County and the TB program there. And we sit atop one of the states with the highest incidence of TB in all of Mexico, Baja California. And so we started the program so we could communicate with that state. Then we started communicating with other states in Mexico. Then we started providing this service for other states in the US who had people returning to Mexico. And then we started branching further and further out. By 2013, we started sending referrals to all countries in Latin America, not only for ourselves in San Diego, but for any state in the US that was interested in using our service. And then in 2016, I had the opportunity to move over to DGMQ. And one of the things we did was then bring Cure TB, and so now it sits within DGMQ's division at CDC. And in 2017, we developed an agreement, an interagency agreement with ICE, Immigration and Customs Enforcement, because they screen almost every individual when they are come into ICE custody. They screen them for TB. You have a very active ICE facility up there in Tacoma, Washington, actually. So they, of course, remove people directly from the ICE facilities. So they have quite a number of individuals diagnosed with TB, started on treatment, and who are then removed. So now we do health department referrals for throughout the US to any country in the world. And we also are doing the ICE referrals for them. Next. And so these are the things that we do, or you could call upon us to do for you. Like I said, our core business is referring patients who are diagnosed with TB, suspected of having TB, but their workup has been in progress, who are started on treatment when they leave to any country around the world. We also have a little activity in the other areas, especially with Mexico. So occasionally we have a kid diagnosed with TB meningitis whose family says, wow, there was someone coughing up blood that we lived with in Mexico. We've been successful at referring that situation to Mexico and actually sometimes finding a source case either not yet diagnosed in Mexico or who was on treatment there. We do some contact notification, again, primarily with Mexico. They have very stringent national norms of what they consider contact investigation and what contacts get screened and put on treatment for latent infection. So we would primarily be referring contacts if they meet the national norms of Mexico, that is under 5 or HIV infected in a smear positive, who are contacts to a smear positive case. We also do the opposite, which is if you had someone who came from Mexico who you diagnosed as smear positive and you can identify the address they were in Mexico when they were likely to be infectious, we do like a courtesy referral to Mexico saying, you know, there was an infectious person in the US, here's their story, and this is their address where you might need to do a contact tracing in Mexico. And finally, we do what's called past history or clinical history request. If you have a patient that you feel there is some important information and they had a recent treatment in Mexico, or in this case, Central America, we might be able to get that information to you on their past history. Now, we say Mexico and Central America primarily for these activities because that's where we have the most experience, and some of this information and notification can be extremely difficult to do. But occasionally we did a past history for an adoptee from Ukraine and actually were successful in getting the information. So if there's some critical information that you really feel you need to have for a patient, we would see if we could get that for you, knowing that a lot of countries are still diagnosed by smear and they don't have cultures and susceptibilities, but sometimes we're able to help in that regard. Next. So this is how it really works. So you send us a referral, the patient's name, information, their clinical story. And then what we try to do is interview each and every patient. And we interview each and every patient, whether they're in a correctional facility or whether they're in your community and being managed by the health department, because one of the most important things that we do is develop a rapport with that patient, because it's not enough, as you can imagine, to send the clinical information to the next country. What's important is getting that patient to walk in the right door in that country in the right period of time and be motivated to show up in that country where we assist them to show up. So we may talk to the patient once, we may talk to them several times, but that is a critical element. At the same time, we do send as much and as accurate information that we can get from you or whoever referred to us about the patient's clinical history to that next country. And we try to send it to the national level in every case, but depending on the country, maybe the state and to the provider level if we're able to do that. We're not able to do that in every country and often have to rely on a national program to get it to a provider level. And then we try to maintain communication with that patient. So we're talking to them, then at some point they move, and we try to maintain a communication with that patient and the health system till we know that they're linked to care in the downstream country. Sometimes we have the patient's phone number, sometimes they have our phone number. Most of the world is using WhatsApp right now, if any of you have used that. And so that's a lot of how we maintain contact with the patient. With the provider, we tend to more do communication either through secure email or through phone calls. And then once the patient is linked to care, then we stay in contact, sometimes with the patient, but always definitely with the national program or the treating provider to know what the outcome is of that patient and feed it back to the appropriate folks who refer to us in the US so we can close the loop. Next. So these are forms. You can go on the website you see there or just CDC Cure TB and it will come up. We have referral forms for the transnational cases. You see to the left, we have one if you're requesting contact or source case investigation. To the right, something that is a little interesting is that there are numbers for California and then there's numbers for the rest of the US, which would include you folks. And when we moved from San Diego to CDC, there's actually 2 people still in San Diego working with the San Diego TB program, funded by the state of California, who do most of the Cure TB referrals for the state of California. So they have their own number and system in California. We do the rest of the US, but we really work together on a daily basis between our 2 programs. Next. And this is 2017, the last completed year, and the places and the numbers where we sent referrals, and in this case, class 3 or verified cases. We had about 800 referrals in 2017, but there were a lot of class 5s or cases still undergoing decisions about where they had active disease or not, but these were the countries where people actually ended up with verified TB. And so you can see a wide array, although the highest number, because that's where a lot of foreign-born individuals come from, and because of our ICE connection, you can see Mexico, Honduras, Guatemala, or year in, year out, are the top 3, but you can see almost every other country, and if you look year in and year out, we've done pretty much every country in the world by now. You see 6 that say the United States, and those, we don't get many, but we're starting a little bit more. We have even a few more now in 2018, and I think moving to the CDC added a bit of cachet, so we're getting more that will actually get referrals from other countries, from Mexico, from maybe El Salvador, but increasingly from other countries. And wouldn't that be great? We're actually developing an alliance with Japan. There's not a lot of business between the US and Japan TB-wise, but they're a country that is extremely interested now suddenly on their referrals from Japan to the rest of the world. So I think this is going to be something that is more and more universal and international. Next. So if you are thinking about those patients who are going to leave your respective areas, there's a few things to keep in mind that makes it all work better. So one is that advanced planning is helpful. Frequently, we do get referrals where people say, you know, patient XYZ moved to Guatemala yesterday, and we've never had an opportunity to talk to the patient. And so it can be, it's not impossible, but it gets quite a bit harder if we haven't been able to talk to the patient and develop a rapport before they leave. In those cases, you know, there's family and we can talk to the family. but it always works better if we're able to talk to the patient ahead of time. The other thing that we find is in a lot of countries, patients prefer to go to private providers. And I'm going to say the Philippines, India, sometimes in Vietnam, and the family knows what private provider they want to go to. It makes it much more difficult because national TB programs around the world often don't have a very good relationship with the private provider community. We are able, if we have very, very good information about the private provider, we have been successful at linking the national programs with the private providers and them having a discussion. But just know that it's helpful for us and for you guys to find out as much as you can about the private provider and how we could reach them if the patient is going to go that route. We really want very detailed information about the TB care. Countries around the world, really as much as you would, they like the very detailed information, you know, date treatment started, can I have the original documentation of the laboratory information? They really want that. So the more we can get of a good story, all the key points that you would want as a provider, and any original documentation of x-rays and lab results and susceptibilities is very much appreciated. One thing that's important to recognize is around many places, although we're all seeing a change now, a lot of places still diagnose by smear alone. So if one of your patients walks into a health center, let's say in Mexico, and says, I was treated for TB in the US, and they do smears, smear testing in Mexico, let's say, and the smears are negative, that person may not be recognized as having truly having active disease, and it's quite a confusion for the patient and the provider. So that's one of the reasons why it's very important, even if you have a well-educated patient who can tell his story, that a good connection is made with the clinical information between our system and the next country to get rid of some of that confusion. And then the other thing I would say is it's extremely important to know why, if a patient isn't on the standard, 4-drug therapy, exactly why the patient isn't on that non-standard regimen. Because in some countries, for example, they have fixed dose combination medication. In Mexico, like they have all 4 first-line drugs in one pill. And it's very hard for them to get the individual medication. So if someone comes to their country, even if they had, it's important to know if they were INH resistant, which is why they weren't on INH in the US, or if they weren't on INH in the US, if they had an adverse reaction, if they had hepatitis or something. Because if they go to Mexico and we're not able to tell them why they were on rifampin, ethambutol, PZA, and Moxie, for example, they might start them on their 4-drug combination INH, rifamycin, PZA drug, and clearly they could have the side effect come back. So the more information, the more details, the more we can help that patient get the care that they deserve when they get to the next country. Next. Not all countries have equivalent DOT to the US. They might call it directly observed therapy. It's something that we cannot guarantee. The countries are going to do what the countries are going to do. We will tell you when we report back the outcomes, what the country told us, but just know that a lot of directly observed therapy, you probably know this, that often the patient has to go to the health centers. Depending on their system, they may give them a week's supply, a month's supply, but they still might call it directly observed therapy. So we'll do the best we can to apprise you of what we think happened. Not all countries have the same medications we have here. Rifabutin in particular is one of those drugs we find that often, unless the US program wants to supply the rifabutin or other medications, that's something that we would tell you ahead of time. They don't have rifabutin, they might have to be on a different regimen. And again, I talked about fixed dose combinations. Some countries, it's very hard for them to get individual drugs. We will try to let you know if we run into that. If your patient's has MDR-TB or XDR-TB, it may take some weeks or months until some countries, centralized countries, are able to get those second-line drugs. We've had programs supply the patient with the second-line drugs for maybe a month or so, depending on the circumstance, so that they can continue their treatment without breaks. And then we use a lot of different partners to try to make these connections and the treatment happen. Certainly the national programs. There's a whole system of international health regulations. Some of you may be aware of the international health regulations, but it's a worldwide system where countries have agreed to notify and work with each other about public health conditions of significance and concern, of which TB is one. And so in that international pact, every country has an IHR, an International Health Regulation contact person, who's very responsive. So if the national program, which is usually where we start to make these connections, is not responsive, and they're not all, we can usually jump to the IHR country contact, who is usually extraordinarily responsive and helps us link with the national program. We also, there are some places, let's say like parts of war-torn Ukraine, but others where the International Organization of Migration is a prevailing partner that we also work with to try to make these connections. Next. And what we do, we think of our service as not really tracking patients, but really another part of the toolkit for patient-centered care, because the patient really is at the center. None of this is going to be successful unless that patient wants to walk in the door and gets the service when they walk in the door in the other country. And so we work with a variety of partners, but it really all circles around that patient to get to treatment success. Next. We do track all of our outcomes. This is just an example from a poster we presented recently that showed our outcomes actually before we joined the Division of Global Migration and Quarantine. So our outcomes have actually gotten better since then because of the connections we're now able to make. But year in and year out, I would say that we always had about 80% that either completed treatment, which is the WHO, is a WHO outcome, meaning they completed the amount of doses they were supposed to complete, or cure, which means they actually had some bacteriological evidence of a cure. Next. And this is just an example. We do a lot of Mexico and Latin America, but this was just an example of a lady. She was actually on the East Coast of the US. She was visiting from Asia. I don't remember her exact entry category. I think she was a tourist perhaps, but she came in the US, delivered a baby. At the time of delivery, she was diagnosed with MDR-TB. She was very shocked and concerned, and before long, she had suddenly left the hospital, left the US with her infant. She was, I think you might have had experience with the travel restriction program, where if you think someone who has infectious TB, you can work with our division actually to ensure that they can't get on an aircraft until they're considered non-infectious. That actually happened in this case. But our role at Cure TB was to try to find her in, I believe she was in China, to find her in China, which was hard because she had just sort of suddenly vanished. But we were able, by working with the program in the US with her family, that we finally got the trust of her family to explain why we were trying to look for her. We actually were able to locate her via the national program. She started her treatment, and she was able to come off travel restrictions, although she didn't come back to the US. And I think she's almost completed with her MDR treatment at this time. Next. And so I guess I would leave you by saying that everyone is somewhere, and even those individuals who 300 or 400 individuals who leave the US every year with active TB. They're all somewhere. Most people that we talk to, I would say, want to take their treatment. They understand about TB if they're educated. They don't want to die of their TB. They don't want to give it to their family. But often when people go back to their countries, accessing TB care can be quite a challenge for them. So they are usually quite appreciative to have individuals who try to help them make that connection and explain what happened in the US and get them connected to care. Next. And I just want to acknowledge all the folks. Many of you may have worked with Carlos. He's sort of the coordinator of Cure TB and really should be giving this discussion. So Carlos and our CDC team, and also the people in San Diego who really work mostly with California. So with that, thank you very much, and I'm happy to answer any questions that anyone might have.